screen. Are we seeing just the PowerPoint? Yeah, thank you. And so we're going to talk about psychological treatment for pain. There are a lot of you here that are much more well-versed in medical treatments for chronic pain than I am, but please feel free to share any insights or thoughts that you have as we go. So there are, as I'm probably preaching to the choir here, lots of different types of treatment for pain. We've got our medical therapies, we've also got adjunctive therapies, and we've got psychotherapies. As a psychologist, that's kind of my focus area for the talk today, but we can talk about all different kinds of therapies for pain. And ideally, the management of pain, chronic pain, is in a multidisciplinary setting. Ideally, these pain clinics, if the pain clinic can include medical management, psychiatric management, psychological management, and an adjunctive management, that is kind of the perfect scenario. So giving people lots of different options for how they could manage their pain, and recognizing within that psychiatric and psychological mental illness is going to affect their pain, right? Both are real. Their pain is real, their mental illness is real. They both react on each other and to each other, exacerbating each other as they go. And so that's an important area that we can't, it's very difficult to effectively treat chronic pain if we're leaving out the psychiatric component. Okay. So let's talk about the difference between treatment of acute pain versus treatment of chronic pain. When we're talking about treatment of acute pain, I'll try to talk a little bit about treatment with kids as well. We're talking about acute pain, you're talking about there could be sensory treatments, behavioral treatments, or even cognitive approaches. That one depends on age, given kids often do better with behavioral approaches. Everything from psychoeducation, self-regulation, talking about this, this kind of comes with psychoeducation, this gradual return to function. A big area for psychology in chronic pain is adherence to care, medication management as well. They talk about interdisciplinary care is always good, but this can be done as independent consultants. So you could refer someone to a psychologist or a treating provider to provide them some of this psychoeducation, self-regulation. When we're talking about chronic treatment of chronic pain, we're talking about a rehabilitation model that's focusing on improving independent functioning, as well as building skills to improve coping and self-efficacy. You'll see that it's not necessarily, the approach is not to get rid of the pain. We're not talking about that here. We're not even talking about reducing the pain when we're talking about here. We're talking about improving independent functioning. And so that's a big area, and a big area to focus on is what are their goals and how do we move them closer to their goals, improvements in functioning, and rather than just saying, how do we get rid of the pain? Because with this chronic pain, we know that we're probably not able to completely eliminate it. And can we improve their coping? Can we teach them new strategies that are adaptive to deal with coping? Can we help them understand, maybe take a radical acceptance approach that, you know, this isn't about eliminating the pain. This is about how you function despite the pain. And this is where the interdisciplinary approach is critical. So I'm not going to go through this list of medical treatments of chronic pain for you. Does anyone have questions about the medical treatment side, which I'm then gonna push off to Dr. Swagger, so. You guys got this. Okay, so there are lots of different medical treatments for chronic pain. And if people would like to have more of a conversation about these medical treatments, I bet we could get an expert in here that would be wonderful to talk about all of these. But that is not me today. So this slide also talks about, in addition to just medications for treating chronic pain, there's also physical therapy, occupational therapy. Again, physical and occupational therapies function. Their job is to improve independent function. That's what they're doing. They're getting people back to where they want to be. Aerobic exercises, and such. Okay. Let's talk briefly about some complementary or alternative treatments. And this is where we talked about adjunctive treatments to pain. Things such as acupuncture, aromatherapy and essential oils, massage therapy, chiropractor adjustments, dietary supplements, lifestyle changes, herbal and homeopathic remedies, traditional Chinese medicine, yoga. All of these have been found to be some adjunctive treatments that are offered within multidisciplinary pain centers that can be beneficial to patients. So let's talk about psychological therapies, and let's kind of take a broad step back. What are the general goals that treating providers, this could be therapists, they could be counselors, they could be psychologists, what are the general goals of treatment for chronic pain? So first, we want to, that's kind of that psychoeducation component, right? We want to assist helping people get some insight and learn how to problem solve barriers. This could include motivation and readiness for change. And so we can help kind of teach them about their pain, teach them about how their maybe mental health symptoms are affecting their pain, what behaviors they're engaging in that are not helping them improve their independent functioning. Another area of another goal of chronic pain treatment is to help change maladaptive thinking and behavior. This is particularly the goal and aim when a therapist is using more of a cognitive behavioral approach to chronic pain, which is an evidence-based treatment. There are some other treatment modalities out there that are less focused on maladaptive thinking and behavior. There may be some component, but in my mind, I'm thinking of ACT, or acceptance and commitment therapy, can be used with individuals with chronic pain. And that would take more, that actually would tell you to stop fighting and trying to change your thinking, but rather kind of take a step back. It's an acceptance. It's more of an acceptance model, and then a commitment towards other actions. So, but many of the general goals include maladaptive thinking and behavior. Emotion regulation. This is where we get help with coping skills. We help people regulate their emotions effectively. Can be a huge coping strategy. Also improving coping by reducing and balancing physiological responses. And then we can promote a healthier lifestyle. We can help them engage in different behaviors. Sleep seems to be an issue frequently with chronic pain. There are psychological interventions for sleep. The goal is to reduce anxiety and stress, which decreases muscle tension and the sympathetic nervous system activation, which can decrease pain. Thoughts, questions? You all are going to be a quiet bunch today. So let's talk about emotions and pain. Anxiety and depression are often very common and comorbid with chronic pain. And sometimes that rises to a level of a diagnosis. Sometimes it's symptoms of anxiety and symptoms of depression, and sometimes it's major depressive disorder or generalized anxiety disorder. There's a correlation between anxiety and chronic pain. So it's important to kind of keep in mind that emotions and pain, we have a chat. They share similar brain pathways. There are increased comorbidities with mood, 80% correlation between anxiety and pain. Does everybody know about ACEs? Anybody want to talk about ACEs? ACEs are adverse childhood experiences. And the ACEs research is really fascinating. It basically looks at different types of adverse experiences that people experience when they're children, or often traumatic experiences. And the higher a person's ACEs score on their measure, the more likely they are to have lots of bad outcomes. Bad outcomes both psychologically, but bad outcomes just health-wise as well. So they can actually tie ACEs or adverse events or traumatic events in childhood to poor health outcomes later in life. And Amanda's probably sitting there saying, Colleen's totally summarizing the ACEs very broadly. But if we want a more conversation about ACEs and chronic pain, we can talk about that as well. Yes. So Elizabeth posted that Campus Health said that increased number of ACEs actually take years off of people's lives. And that is true. And often because of negative health outcomes is why it takes years off of people's lives. And it's why it's really important that we are kind of managing and helping people who have experienced a number of ACEs. So important to keep in mind that mood and pain has a reciprocal relationship. As I mentioned before, when somebody's pain increases, it tends to bring about a worsening of mood symptoms. Increased pain, increased mood symptoms, or more depressive or anxious symptoms and more pain. So they're working together to kind of exacerbate each other. They're, like we said, common comorbid disorders, anxiety, major depression, bipolar disorder, even somatic symptoms. So you're thinking that they are highly focused on their somatic presentation and fearful. So sometimes there's a question of what comes first, kind of that chicken or the egg. You're looking at, is it depression leads to chronic pain? Is it that chronic pain leads to depression? Oh, Cheryl, it's nice to see you joined us. I don't know if I missed you during the introductions. Cheryl noted in the chat that she read the other day that there's been talk of adding the pandemic into ACEs because of its effect it's having. That makes sense. Cheryl, would you like to comment further? Would that mean that all of us started ACE #1 since we've dealt with the pandemic? Or would that be people who have experienced long COVID? How do they want to?
The brief overview that I saw of it is that they're just looking to add it into everyone's ACE score just because of how far reaching all the effects have been on all of us, not just with the physical aspects of it, but how it's impacted all of our mental health. And I wish I had saved the article, but I didn't, but it was really interesting.
Do you know where the article might have been from?
No.
Okay.
And I unfortunately no longer have it open in my 97 tabs, so.
Mine just told me you need to free up space by closing some tabs. So
yeah, I get that all the time.
Maybe somebody can do a quick search for ACEs and the pandemic, because I do think that's really interesting and kind of scary. But we all know that there's a mental health crisis. It's already started with the pandemic. Okay. Questions, motions, pain. There's also research to suggest that mood influences people's perception of pain, and their perception of pain influences their mood. So keep in mind that pain is real, but pain is a subjective measure. And so how people perceive their pain can affect their mood. If they perceive all pain at a 10 versus being able to really differentiate we always talk about that scale of 1 to 10, right? Where's your pain today on a scale of 1 to 10, 1 being the best and 10 being the worst? And people who have a hard time differentiating, like they couldn't tell you what's the difference between an 8 pain and a 7 pain. That can influence how they perceive, right? That's how they perceive their pain, because all pain is going to be maybe more distressing to the people. Oh, wonderful. Tanya found us the article. I'll tell you that I really despise PsychNet because I can never actually read the article. It just pulls up the abstract. Oh, as I say that to you, it's telling me I can pull up the PDF here. The rise of adverse childhood experiences during the COVID-19 pandemic. Wonderful. Everyone has that link. Amanda, I saw you popped on here. Did you have a question?
No, I was just done blowing my nose, so I got on.
Oh, I'm sorry. Tanya found an article about ACEs and COVID-19. She's wondering if it's the same article that Cheryl was talking about.
I don't think that it is, but I'm trying to find it, but I haven't. But if I do, I will share it in the chat.
Wonderful. Thank you. So let's talk a little bit about cognitive distortions and how these maladaptive thinking patterns can influence pain. And so these are some of the cognitive distortions that are out there. The first one noted here is overgeneralization. And so overgeneralization is when individuals think that there's kind of this never-ending pattern of defeat. They kind of, those are the, and you'll see some of these kind of overlap, but I always think of overgeneralization as they take something that's specific to one situation, but they generalize it to all the situations going on in their life. And so if I have chronic pain and I might be defeated currently physically, that means that everything is kind of negative, or I'm going to fail at all of these different areas of my life. Okay, and Elizabeth put some other articles in there for us. Thank you. Elizabeth, can you pull all the links and make sure we get them in our summer email?
Absolutely.
Thank you. Another cognitive distortion is labeling. It's this extreme form of overgeneralization, but it's a label to the individual. So this could be like, I'm a failure, labeling self, or that person is worthless. So rather than, so as part of overgeneralization, it's making kind of a statement about a person's worth. We're labeling them. All or nothing. This is our black and white thinking. This is, I'm always going to be in pain. I'm never going to be able to walk 5 blocks. I will never be able to take my kids on a bike ride. Those kind of all or nothing, black or white thinking gets us into trouble because the world is usually somewhere in between. The real situation is usually in the gray in between, but the gray is not concrete, and the gray is not, the gray has uncertainty, which makes people in general really kind of uncomfortable. And so fortune teller, predicting the future and always predicting it kind of in a negative light can be a cognitive distortion. So mind reading, I often think of mind reading as them wanting to read, thinking that other people understand what they're thinking, that everybody thinks like them. There's also this concept of assuming that the person knows the reason behind a behavior, but they don't check it out. And so I think about that as, my doctor didn't respond to my chart message, and it's been 3 hours. They must not want to work with me anymore. Another cognitive distortion is should statements. This is one I go over all the time. Shoulds, should, could, would, have to. These kinds of statements, all they do is they set a bar. they set an expectation that's often set too high. That means the people often aren't going to meet that expectation. Either you're setting them for somebody else or you're setting them for yourself, and they're not easily or even attainable. And so when we don't attain that expectation that we set, I should never eat candy. Well, then that first time I eat candy, because I've set that impossible, all or nothing expectation, I feel really guilty, disappointed in myself, because I didn't follow through. So those are kind of words that we look to avoid. Emotional reasoning kind of gets into we have this logical side of us, we've got this emotional side of us, and we want to balance the two together, rather than focusing just on that kind of emotional reasoning. And then catastrophizing is exaggerating the impact or importance by either minimizing or magnifying whatever the issue is. And so it's making what they call it, making a mountain out of a molehill. It's a way to think about cognitive distortions. Let's talk specifically about catastrophizing, how it works with pain. So catastrophizing, and there's actually a measure. When I do chronic pain evaluations, we use a measure of catastrophizing because it's a risk factor for how successful, specifically in my case, how successful spinal cord stimulator procedures are going to work. And so catastrophizing correlates strongly with pain-related interference, disability, and depressive symptoms. It's this negative emotional, cognitive, attitudinal pain coping strategy. I feel I can't go on. There is nothing I can do to reduce the pain. This pain is going to be here forever. And so they talk about kind of the order for improvement. We go from catastrophizing to understanding that pain may be a disability to then recognizing it as pain. With catastrophizing, it really influences the person's ability to see successes, to see that there is a possibility for improvement. Because they're taking everything to the extreme, it's really hard for them to see that, okay, I walked 1 minute today, I couldn't do that yesterday. Next week, now I can walk for 2 minutes. And it's kind of taking those chunks and those successes in small doses. That's hard to do when you catastrophize. Let's talk specific psychotherapy skills for chronic pain. So this is some basics on cognitive behavior therapy, or CBT. There are meta-analyses that have been conducted that support that cognitive behavior therapy improves quality of life, decreases depression, decreases pain intensity, and pain-related interference. CBT includes some behavioral elements, so behavioral strategies like relaxation, and behavioral activation. That's a big one, particularly if there's kind of depressive symptoms. So the cycle of depression is that when people start to feel depressed, they start to engage in less activities that are meaningful to them, which makes them feel worse. Then they engage in less activities, and it kind of spirals down to them limiting their access, opportunity to pleasant events and events that are mastery or like purposeful in their life, which then kind of reconfirms their low mood symptoms. And so with behavioral activation, we have them start doing pleasurable events again. We have them start doing activities that are meaningful and purposeful and show mastery to help kind of stop that cycle and start introducing things that are positive again. Another component of CBT is cognitive restructuring. We just went through all of that, replacing maladaptive thought patterns like those cognitive distortions with and incorporating and promoting kind of self-talk with adaptive statements. So it's kind of counteracting those cognitive distortions or changing their language a little bit. For example, in all or nothing thinking, they might say, my pain will never get better. And rather than thinking, my pain is really high today, but yesterday was a little bit better, or last week I had a good pain day. And so it's getting really specific about, and it's not that every day is awful, but that some days are harder than other days. There are people that use hypnosis. And what hypnosis is going to do is focus a person's attention, which should increase their kind of a state of relaxation and increase their sense of control. I am not trained in hypnosis, but we can talk more about that if people have thoughts about it. There are there is evidence for the use of kind of hypnosis in some of these areas. It's not kind of as wacky as it sounds on the surface. They're not going to make you like cluck like a chicken, such as it's seen. And a big part of CBT is coping skills, understanding coping skills. It's teaching problem solving. It's teaching them to decrease maladaptive coping, to view the pain experience as controllable. And this takes time. This is a longitudinal with small practice as they go. And this can be done in individual therapy. It can be done in a group setting. It can be done with peer support. It can be done with loved ones as well. I'm going to stop because I saw the messages pop up. Looks like Cheryl, this isn't the one she was looking for, but it's interesting to read regarding ACEs scores and how the pandemic has highlighted many of the disparities that often contribute to ACEs score. Thank you very much for that, Cheryl. We'll get that sent out to you in the review. Okay, let's talk a little bit more about CBT. So I love this graphic we have here. This kind of talks about the core components. With CBT, we're looking at this triangle between our thoughts, our feelings, and our behaviors. You'll see that within this triangle, their arrows go both ways because they all impact each other. Our emotions influence our behavior and our thoughts influence our behavior and our emotions, our behavior influences our thoughts and our emotions. And so, sorry. So CBT often starts with education, particularly with pain management. We're talking education on the mind-body connection. Then it often goes into those behavioral strategies. We talk relaxation and distraction training. This could be diaphragmatic or deep breathing, progressive muscle relaxation, and guided imagery. With pain, sometimes is increased muscle tension in certain areas. And so teaching the progressive muscle relaxation, teaching them that they can release and relax their muscles themselves can be really helpful. Then we have behavioral training. This is the behavioral activation I just talked about. That included with that, we'll do pleasant event scheduling. So helping people get back on a schedule, putting in specific times during the week that they're going to engage in activities that used to be pleasurable to them. And then helping them understand kind of the cycle of activity and rest, and that, you know, pushing themselves too far and how that affects their pain and their functioning ability versus, you know, having those set rest times. Behavioral training also includes goal setting, which is getting right at that independent functioning, right? We're going to have them set SMART goals using these psychological strategies to improve independent functioning. And so we're not going to say, I'm going to feel less pain today, but we're going to say, I'm going to walk for 5 minutes, 3 times this week. And really kind of operationalizing those goals and in a way that it helps to improve their independent functioning. And also in really small increments that is not, you know, it's not about kind of pushing them to the extreme or breaking or like increasing their pain, but it's kind of slowly, gradually increasing functional behaviors. We know about that cognitive training for that catastrophizing, cognitive distortions. So catastrophizing, we talked about it predicts higher self-reported pain intensity, higher levels of pain behaviors, higher pain-related disability, greater use of pain medication, and higher healthcare utilization in every population that's been studied. That means pediatrics, adolescents, adults. It correlates strongly with pain, pain-related interference, disability, and depression. When we talk about improving pain self-efficacy, is this confidence in the ability to engage in actions that accomplish a reduction in pain. So it's kind of their ability or their belief in their ability to engage in actions that will reduce their pain. So that goes back to that kind of catastrophizing, right? There is nothing I can do to reduce this pain. It will never go away. That's kind of the opposite of this self-efficacy. We want them to feel as much as they can to be in control of reducing their pain. I have the ability to control some reduction of my pain. Of all the psychological variables that have been studied in pain self-efficacy is consistently the best predictor of almost any given outcome variable in prospective and cross-sectional studies. So very, very important one. And then other strategies that are built into cognitive behavior therapy, maybe sleep hygiene. And so the sleep hygiene, we also have cognitive behavior therapy for insomnia, or CBTI, that would look at other sleep issues, but even just basic sleep hygiene, talking about what the environment should look like in the bedroom, that the bed should only be used for sleep and sex, that it should be quiet, without noises, dark. I see Elizabeth laughing over there, but those are you shouldn't, if you're having sleep problems, not doing your homework in bed, not watching TV in bed, not staying in bed all day. All of those are some of the sleep hygiene stuff that can be helpful to people. Also with CBT, some of it can be social skills training, and that kind of helps that behavioral activation, getting people out more if they feel more confident in their ability to interact with others socially. And we could do additional stress management as well.
I am guilty of like all the bad things for sleep, just so you guys know. Just throwing it out there. Slept with a TV since I've been little. I cannot sleep without it at all. I've tried. I need to like try the Calm or something app. I have used my bed for homework many a times where I'm alternating between the desk and sitting in the bed and like laying all my books out. So yeah, I've messed that up for forever. So that's why I might explain why I have a hard time sleeping.
Yeah, I wrote a report in my bed till midnight last night. So I also am very guilty. I think the important thing to keep in mind with sleep hygiene is these are strategies to use if you're having trouble sleeping. If, like me, you're so exhausted, you write a report till midnight and then you fall asleep immediately, less of a concern. However, if I'm then awake for an hour afterwards, I probably should take a look at some of those kind of sleep strategies. So if you're not having trouble, if it's not interfering with your ability to sleep, then take or leave sleep training. So I mentioned this briefly. Acceptance and commitment therapy is another type. So we've got cognitive behavior therapy over here, and we've got acceptance and commitment therapy over here. It's considered a third wave therapeutic modality. It's actually created by Stephen Hayes, who was a graduate student of WVU's psychology PhD program. And so he actually proposed ACT as being a very behavioral treatment because that commitment part is all about action. It's all about moving your life more, making your life more meaningful, moving it forward in ways, improving it in ways. But rather than those maladaptive trying to change something, they go with this more acceptance approach. So ACT is about increasing psychological flexibility. So you think about those cognitive distortions and then black or white thinking, that's inflexibility. So increasing psychological flexibility, helping patients understand that pain is a part of their life, learning how to step back from thoughts and emotions instead of letting them drive their actions, focusing on what matters to them, and finding ways to live out those values despite pain, despite a mental illness, despite a loss, all different aspects that ACT can be really helpful for. So with the acceptance piece, you're allowing pain to be there. You're kind of trying to separate yourself. You are not your pain. Pain is something that you have. ACT uses a lot of mindfulness training techniques. They talk about confronting prior agendas. They look at, like, they call them creative hopelessness. There's a lot of different analogies that are often used with ACT. And so that's a problem of focusing on symptom reduction and control, is that they feel kind of this, that the prior agenda was to reduce symptoms and control their pain. And to confront that, we kind of step back and we say, I'm not going to control it. I'm not going to actively reduce those symptoms. I have kind of this acceptance piece. My favorite part about ACT and what I find really beneficial with people is this values component. So ACT is really one of the big components of ACT is identifying what a person's values are, and then mapping those values, mapping their actions in life onto those values. So if a person's value is family, then it's asking them, okay, on a scale of 1 to 10, how well are you living your life, making your decisions, planning your time in accordance with that value of family? So they may say, oh, I'm at like a 4. Okay, well, let's have a conversation now of how we can get you from a 4 to a 6. How can we increase you living by your identified value of family? Well, I would love to play with my grandkids more. I would love to have more time with my grandkids. Well, how can we do that? Well, my grandson has a baseball game 3 o'clock on Thursday. Okay, so how can we get you to the baseball game despite your pain? So again, we're not reducing the pain, we're not controlling the pain, but we're saying, despite having pain, I'm going to live my life, and how can I continue to live my life? And the way that we get to a meaningful life is by really understanding what our values are, because our values should drive the things that we do in life. And so that's building that commitment to value-based action. And the values piece and the committed action with the values is, I think, really helpful with depression. Really helpful with depression. Okay, so a little bit more about ACT and pain. What time are we at? Okay, we're at 1:45. When we talk about kind of the acceptance piece, because a lot of people kind of misconstrue this. They think, oh, this is just like resignation. I'm just giving up. I've given up. And that's not what is meant by acceptance or radical acceptance in the ACT program. It is acknowledging that difficulty. It's acknowledging the negative emotions that come along with that difficulty without escaping or avoiding them. It's sitting with them. To truly accept pain, their chronic pain, they have to kind of sit with them and sit with the negative emotions that come about. And it's to kind of observe weaknesses and kind of in the best non-judgmental way you can, but also note that the strengths that they have. And they do this through mindful meditation, taking a non-judgmental, helping them engage in non-judgmental self-awareness, which will also help reduce anxiety. It helps them stop focusing so much on the past or the future and stay in the present moment. They talk about cognitive diffusion. This is another strategy used in ACT. And it's having them kind of separate, observe their feelings and physical sensations, but counter negative self-talk in realistic views. I was thinking of cognitive diffusion as kind of separating ourselves from our own thoughts and feelings. Like, I have this thought that I'm in pain. I'm not pain. And so it's kind of pulling those apart a little bit. And again, we go back to those core values. What are their core values? Family, intimate relationships, education, friendships, recreation, physical wellness, citizenship, spirituality. There are so many values that people can choose from. What is important in their life, and how do we use that, take action with that to move forward? Okay. Other strategies often used in pain management, motivational interviewing, such as we use with substance use disorders, is where motivational interviewing initially came from. And that's the motivational interviewing, is helping people when they're in that, helping people figure out what stage of change they're in and help move them towards the action phase, right? They may be contemplating change. How do we get them further? How do we get them to enacting those change? Because the things that we may need to treat are often not reinforcing to start with, right? So they need, maybe physical therapy is what they need, but physical therapy is really painful for them. And also with this catastrophizing often comes like a fear of pain, the fear of being in pain. So I'm going to avoid physical therapy, even though it could help me, because I think initially it's going to cause me a lot of pain. And then mindfulness, we talked about that one. So here's cognitive behavior therapy with families. And so this is particularly helpful when you're talking about pediatric chronic pain. You're still using a lot of those CBT skills that we talked about before, but this is kind of what the whole family can do when it comes to CBT. And one thing we can do to help families is help them improve their communication skills, help parents kind of be reflective, make reflective statements, be more reflective, be more direct in what they need or they want, be more organized and planned. With the reflective thinking of, I was thinking of emotions and making sure that parents are kind of validating and reflecting the emotions of their children. We can also coach families and help them model positive coping. Operant strategies, these are your rewards and punishments. So we can set up behavior plans. This could be like focusing on adherence to pain management treatment. We can teach them about selective attention, paying attention and rewarding or paying attention and ignoring other behaviors. We can encourage them to resume normal activities. And they talk about reversing the sick rule in their children through function. So this is kind of not letting the child take on the sick role, but rather we're moving that kid towards functioning more. And that goes back to resuming some of those normal activities. And a lot comes from family systems therapy. And family work is important because many times teenagers with chronic pain also have a parent that has chronic pain. Apparently there's a group of researchers who is studying this intergenerational kind of transmission of chronic pain, which I think is fascinating. So here is a case example. 13-year-old female, progressively worsening shoulder pain since she was in a competitive swim meet. That was approximately 6 months ago. With a multidisciplinary team, she is given the psychoeducational, she's She begins to learn how her body processes pain based on psychoeducation on mind-body connection, maybe some more mindfulness, progressive muscle relaxation. Her functioning is improved. Maybe it's with that values-based approach, moving her more towards her values. She's returned to school, so maybe some of that family CBT work is working in there to get resume normal activities, to not allow her to take on the sick role. And she's developed new coping strategies. And with all of that, in addition to other probably medication-based therapies, her pain has improved. Questions? All right, I'm gonna stop sharing so people can ask questions.
Thank you so much, Dr. Lillard. Really appreciate it. You're just like so natural, like chilling with her drink, you know, and like I'm with it, like prep for it. I'm like, I can do this. I might not seem nervous when I start sessions, but sometimes I still am. Does anybody have any further comments or questions or anything, you know, that they've experienced, maybe personally or with some patients?
That's a quiet bunch.
It is a quiet bunch today. You can also chat it in honestly if you want to too.
Are we all caught up in the chat?
Yes, I believe, yeah, we are. And I will definitely provide all those excellent resources. Because I think that would be an interesting topic. Or, you know, you can chat in different topics if you guys have anything else you want to discuss or further. Like, I did not know about the ACE. I mean, I probably wouldn't know unless I'm in psychology, but I didn't know what the ACE whole thing until the campus mental health. And I was thinking, oh my gosh, they were talking about like 20 years off of some people's, you know, individual lives, depending on how high it was. And that's, you know, really take that into account. People are going through and how much it does impact your health. That's really sad. I was telling Mitra we should do a relationships in COVID, like romantic, like dating and being married during COVID. And the stress that comes along with
I know of multiple people now who started dating either just the beginning of COVID or just before COVID and have gotten married. And it's kind of interesting that they know no other. They only know each other in COVID times. I had one friend, they met like they started dating right before COVID and they got married last July. And everybody was teasing the husband because his now wife had never seen him during a true March Madness. And they were unsure of how she was going to cope with that true basketball fever that could hit.
That's amazing. I'm assuming then they're still married, right?
Well, they got married in July, so we haven't March Madness yet.
So coming next year. Okay.
Yeah, or coming like.
I'm so bad with sports, guys. Not gonna lie.
Well, WVU is not in a place for you to get excited about sports. So.
All right. Well, if there aren't any other questions or anything, or if you do have them afterwards, please, you know, just shoot them our way, and we'll be happy to reach out to everybody. And our next session's March 16th with Amanda, and she's going to be discussing abnormal attachments. So we look forward to that, and I hope you guys have a great week. Thank you. Bye-bye.
Thanks, everyone.